Thank you for inviting me, and thank you, Clemens. I was just thinking, listening to you, Penny, that I use any opportunity to talk about my new 4-month grandson. And when I arrived at the weekend, his parents were reading a book called Precious Little Sleep. Anyway, so I'm here today to talk. I do, like Deborah, make people cry often, but usually for different reasons, not about awards, but because I talk about sad things. So I hope I won't make too many of you cry today. But there may be some triggers in what I'm going to say. So let's see. It's nice to have some audience of all ages, whoever you are. Thank you for feedback. So I think wherever you end your life, it's got to be a good ending, whether that is a care home, at home, hospital. Where else could you die? Prison. We need good endings wherever you are. Actually, I want to link with one other talk this morning. I was asked last week to go, and somebody said, could Dr. Taylor come round? I've got a donation for the hospice. I have worked for 34 years. I've been a doctor for 44 years. I've worked for 34 years in the hospice and palliative care sector. So I was asked to go and receive a donation. I was very pleased because hospices are short of money. When I arrived there, there were 44 unopened packets of tenner pads for the hospice. There was no money, just lots of incontinence pads. So I just wanted to link in with your talk, Zena, which I very much enjoyed. So a good death in the bed you die in. And lots of people die in care homes. In the UK, it's between 23 and 25% now, same as in the US and Canada, even higher in Scandinavia and the Netherlands. So it's important. The picture up there is Teresa, one of the nurses I work with, and Mary, one of our patients who actually got home and died at home. And we know this is going to be a bigger issue in the future. These are startling statistics. I haven't got too much data to share, but the number of people over the age of 80 in the UK is going to double in the next 40 years. So what's the impact of care homes and palliative care? Actually, I think I can read from here. Now, 80% of people who live permanently in care homes, where this is their home, 80% die in their care homes, but that means 20% don't. And that's a lot of people. That's 16,000 people in the UK go into hospital towards the end of life. I'm glad to say that Nightingale Hammerson, it's much higher than that. And I mean over 93, 94% of people, when they come to the end of their life, they are cared for in their home here or at Nightingale in Balham. There's also another issue that is a growing issue, is that people go from home into hospital into a care home for a very short time, and many of those people are dying, and I am not sure that care homes are really set up to look after people for 2 or 3 weeks in the last week of life. Care homes their care is based on relationship, and you can't always develop a relationship in such a short time, so that is a challenge. Nationally and internationally, actually internationally, 33% of care home residents die in hospital. And that's a shocking statistic that needs to be improved globally. So you might have been living in a care home for 8 years, and then for your last days of life, you're whisked into a chaotic ward in a local hospital. And we need to find ways to stop that. And this is my last data slide, and there are QR codes for anybody who wants to look up the original papers. By 2040, care homes are likely to be the commonest place where people die. So I said earlier it's 25%, it's going to be probably nearer 50% by 2040. So this is a great quote from T.S. Eliot: home is where one starts from. So what is interesting is to think about, what does home mean? And Aileen Collier, who is a researcher I know, who's now in Australia but was in Scotland, she did a big research study on what is the meaning of home. And if I asked you to shout out, what does home mean to you? I don't think I've got time to do that. But when I've done that in a workshop before, people shout out photographs, garden, familiarity, family, relationships, memories. And I think that's what we are creating in our care homes. And we can create home and homeliness in care homes, and we often do. So if I begin to think about the difference and the similarities between hospices and care homes, on the right, the purple blob, we tend to look after, or have in the past looked after, younger patients. Commonest age is, sadly, 40 to 70. Care homes, the average age is over 85, nearer 90 now. We definitely have expertise in symptom control, but we do not have the dementia expertise that care homes have. But what unites us in the middle is person-centered care. So how can we build on that? So if I spend a couple of minutes thinking, what is a good death? Again, I could get you to shout out, but I'm not going to. All of the studies, and there are many research studies exploring this rather strange concept of a good death. Some people might say a death is never good. That's a whole philosophical debate. But it is, in my experience, it is about communication, about thinking ahead, about trying to discover what is most important to that person. And one of the first questions I ask when I meet a new resident in the hospice, I say, what's the worst thing at the moment? We don't go in with an agenda. People have told me, oh, pain is the worst thing, or constipation is the worst thing. But when I ask that question, what is the worst thing? The worst thing is often leaving my family, leaving my daughter, leaving my sister, leaving my brother. So we should not make assumptions when we want to discover what matters most to people. So it is about asking brave questions. So a good ending is no emergency admission at the end of life. Confidence to ask those tricky questions that we avoid for most of our life. Advanced care planning is the name that the NHS has given to trying to plan for the future. If things get worse, where would you like to be? Where would you like to end your days? Those are difficult questions, but actually, nobody ever dies from a difficult question. So it's worth asking. So let's look at what defines hospices and what defines care homes. So again, in my experience, and your experience may differ, we do have a multidisciplinary team. And that means doctors, nurses. Nurses are absolutely at the heart of hospice care. Chaplaincy, social workers, physiotherapists, occupational therapists, art therapists. We're very lucky. We have brave conversations, as I've said. We're pretty good at managing symptoms, pain, breathlessness, and constipation. We have pretty high care ratios compared to the NHS and definitely compared to many care homes. We look after all ages. At the moment, in the small hospice I'm currently working in, we've got patients ranging from 24 to 101. And that's quite difficult. And the hospice population is now younger patients with complex symptoms from cancer, not always dying. Many of our patients go home feeling better. And we have many myths to dispel about hospice care, in the same way that we need to dispel myths about care home care. So we're working in a similar media challenge. So all ages, we're pretty good at recognizing dying, not always. I can't remember, I think one patient a year goes into hospital, maybe to have something unblocked or for urgent surgery where it's really appropriate, but incredibly rare to go into hospital at the end of life. And maybe a big difference, but I know at Nightingale we have great medical support, but many care homes have very poor medical support at the moment, although it's getting a little better. Every patient is reviewed by a doctor daily in most hospices. Oops, I've gone backwards, sorry. We do go the extra mile. We've had weddings. I'm waiting for the first wedding at Nightingale Hammerson. Do you think we'll have it? Who knows? You can get married when you're very old. We are pretty hot on making sure that everybody has finalised their wills. I don't ask that question, are your affairs in order? Because once a husband said, I've never had an affair. So that's, just look at your language. We supported Yvette to get married. She got married about 4 weeks before she died. And we supported Nahida to go on pilgrimage to Mecca. She was in the hospice. She had advanced breast cancer. She was very breathless and ill. Her daughter took her for her last pilgrimage to Mecca. We supported her the whole journey through WhatsApp. She got back safely. She came to the hospice. She was discharged home. She died at home about a week later. So going the extra mile. And again, I know many care homes go the extra mile, but how can we work together to go the extra few miles? Better talk quickly. So what defines a care home? There are many of you here who work in a care home, and you're probably better at defining a care home. I think you do have brave conversations. You attend to what matters to people, possibly less expertise in symptoms, as I've said, but more expertise in dementia. You do have lower care ratios than hospices, and there is a higher risk of hospital admission, and you definitely have less input. When I say you, I'm not talking about Nightingale, I'm talking about care homes in general. But you can provide, and you are providing care at scale, which hospices are not. So the differences are about funding, staffing, ages, and focus. Now, I haven't got time to talk about the assisted dying debate, which I know is in the media a lot this week and will be for the next 3 weeks. I'm more interested in assisted living. We know that if assisted dying becomes law, and it may well, and I'm not going to share any personal views on that, it will only be relevant to 5 or 6% of the population. So I'm more interested in better care towards the end of life for the other 94%. And I think that's where our energy should lie. Some brief research. This was research done by Marie Curie, which showed that if you died in a care home, you were less likely to have your family at your bedside when you were dying. That's the bottom blue line. And that's possibly that the end of life phase wasn't recognised early enough, so families weren't called in. You're less likely to have any expertise from the local palliative care team. That's the middle bar, less palliative care. The other big difference, and I think this is an opportunity for Nightingale particularly, and probably many care homes, is to continue the bonds with families after somebody dies, and to think about not just signposting to bereavement care, but actually developing some sort of bereavement service yourself. And I think that's about the health of the community. We know that bereavement is a huge mental health risk, and many families where somebody has died in a care home never hear from the care home again. And I think that relationship could be expanded on. So the similarities are definitely, we share stories, we focus on relationships, both in hospices and in care homes. So just a few papers which pick out some of the challenges of working in care homes right at the end of life. We know that dignity is challenged by long waiting times when a call bell is rung. We've heard from Rosalind how single-handed care could really reduce that waiting time. In our hospice, we now have single nurse administration of controlled drugs. Normally it would take 2 nurses if somebody rings a bell and is in pain, it used to take something like 11 minutes to get some analgesia. It now takes 3 minutes. So people get their analgesia more quickly because one nurse can do the counting and the signing of strong analgesics like morphine. More research. We need more nursing input, probably, in our care homes. We need more social care nurses as well as our amazing healthcare assistants. And this was an amazing study, I think, from Scandinavia, which was based on focus group discussions with nurses to find out how they approached the end of life and how they struggled to recognize the end of life. And the outcome was, or the evaluation was, we need more trained nurses. So this is a quote from one of my heroes, who is sadly no longer alive. Professor David Roy was a Canadian ethicist, and he talked, there's another quote from him later on. He said, we need, or most of us would want to die without a frantic technical fuss. That means no drips, no tubes, to squeeze out a few more moments of biological life. And I remember my mother, who died 14 years ago now, age 92, my sister's a doctor, and we had a conversation with Mum about how she wanted to be cared for as her health was deteriorating. And her advanced care plan was only 2 words. She just said, no, oh, actually it was 3 words. She said, no tubes, please, which meant no drips, no dialysis, no ventilation, no artificial feeding, no peg tubes, so no tubes. That was very easy. And that guided us in our care towards the end of her life. And I think this quote, if you read it to many people, they don't want life prolonged at any cost. And I know there is challenges about that. There's religious challenges, but not extending life is different from shortening life. We're not into shortening life. We're interested in supporting natural endings. Okay, I'm going to pass over this slide. But just to say, there's an enormous amount of work going on all around the world in supporting a palliative approach in long-term care. These are 3 leaflets. I was lucky enough recently to go to Montreal to a big congress, palliative care congress, and there was a big focus on long-term care. And these are 3 leaflets from an organisation supporting palliative care in care homes in Montreal. Yes, we can count how many people die in a care home, but I'm not just interested in activity and how many people die where they want to die. I'm interested in the experience of care. And how do we measure experience? Some of it is about 0 admissions at the end of life, but it's about the family satisfaction of care. It's about less agitation, better sleep, less pain, continuity. And we're not always seeing that in the NHS. And many care homes are struggling with staff. So do the staff who are looking after you really know you and know what matters to you? I didn't know you were going to be here, Judith. So there we are. I really didn't. But this is such a wonderful example of person-centered care and understanding how different generations, whether it's teenagers. I know at Nightingale you've got an amazing group of Austrian volunteers contributing, young student volunteers contributing to care and support. So how can we mix generations in all care homes? Oh, 2 minutes, right. Okay. Amazing things go on here. You've heard about many of them today. We have a very high percentage of people dying here when their time comes. Loads of awards for end-of-life care to Clements, to Nuno, and to Daisy. And I think here are some photos receiving the Gold Standards Framework Award. Right, I've only got 2 minutes. I might speak for 3 minutes, though. So, mortality. Does everybody here accept that one day you might die? So I was at a conference in Canada, and there was a guy from New York looking at this poster, and he said, "Thank goodness I live in New York." Anyway, we have to think about the future. We all think we're going to live forever. The Daily Mail, I hope none of you read it, will persuade us that we're going to live forever. So what does the future hold? So my last 2 minutes, just some thoughts about how can institutions such as care homes and hospitals accept that palliative care is good care. An old lady once, when we were talking to her about palliative care, she thought I said palace of care. Well, there we are. We need to partner with other organisations, perhaps with your local hospice teams, perhaps with your kidney teams, perhaps with your diabetic teams. Partnership is the answer. I will pass on quickly. There are some great tools. We've heard about some of them this morning. The shadow tool, which helps nurses to recognise when end-of-life care might be, when end-of-life might be coming on. And this is enhanced health in care homes. It's a huge NHS initiative. I haven't yet seen the benefits, but this is about local doctors, GPs, spending more time in care homes. And I think it's happening slowly. Deborah, it'd be interesting to hear your view on this programme. So, fixing the broken image of care home. Well, we are starting to do that today, I think. But sadly, there is still a taboo about going into a care home. And we need to use all of our media power to change these messages. So I think I'm going to move on to I was going to talk a bit about digital innovation, but I'm sure we'll hear more about that next year. I think I learnt from Jenny from your recent visit to Norway, the concept of welfare tech. There is a lot of technology that could help, that could free up time for care workers and nurses to have more care. So I better mention Reach though. Amazing website now on the Nightingale, part of Nightingale's innovation to develop ways to support care at home and indeed in care homes. So have a look at the website. And I think that's about it. So this is my last slide. Again, a quote from David Roy. All people want is to die in the presence of people who know how to drop the professional role mask and relate to others simply and richly as human beings. And I know that most of you here do exactly that. Thank you.
Thank you, Dr. Taylor. Does anybody have any questions?
Ooh, okay.
Hi, it's Zena again, sorry. Ros, you talked about the bereavement for the families. Do you think that's a big difference as well for the staff? Because I think hospice care gets a lot more psychological support and clinical supervision perhaps than care home staff do. And we obviously also, we know that care home staff are dealing with death quite regularly. The pandemic really brought that to the fore. So I guess is that another part of the system that we need to fix to ensure that people in care homes feel that they can grieve for those residents?
Yes, you're absolutely right. And because of the scale of care homes, most care homes have as many deaths as small hospices. And I know that Nightingale have introduced Schwartz rounds to reflect on the impact of people dying and the relationships that you have at Nightingale. They're often for many years. Residents become family members. And yes, I think supporting families but also supporting staff is key, and there are many ways to do that. Nurses are very good at reflection. We should do more reflection. Doctors are hopeless at it.
Hi, I'm Louise. I'm the co-chair for London for the Social Care Nursing Advisory Councils. Just a quick question. It's quite similar to Zena's, but I'm seeing a lot of ICBs block booking beds within nursing homes for fast tracking people out of hospital. And what I'm seeing is that the crashing and burning of the staff, because you talked about that relationship, which is so important, both while someone is dying and afterwards, and that's lost for those families and indeed for those individuals that are coming in. And I just wondered if we're doing anything about that, because I'm struggling with this, about what I'm seeing, because people, I'm told, are arriving and sadly dying within days, 24 hours. That must have a huge impact. That does have a huge impact on the staff, but also on the families as well.
And at one of our care meetings last week at Nightingale, we talked about there's more and more requests for beds from St George's Hospital and from the Royal Free for people to come for their last days to Nightingale Hammerson. And it is difficult because you don't have time to get to know the family. You can get things very wrong, especially as I don't know how many hospital colleagues are here, but the information that's given from the hospital to the care home is appalling. Often not enough clinical information, basic information about moving and handling and nutrition and issues with the family. So certainly at the hospice, we absolutely insist on that information, and I'm going to think about how we can insist to get that information from hospitals. But I think it's going to continue to happen, so we need to think about how care homes are going to adjust to that sort of rapid fast-track ending, because it's a very different type of care. And I'm sure some of the nurses here could say something about that.
Yeah, I think, first of all, thank you. That was a really inspiring and interesting talk. But I was thinking that it's not ideal people coming to care homes for a few days, but it's certainly, if they have the information, it's not worse than hospitals, because it's not as if they're going to have continuity and knowledge in the hospitals. And it is a nicer, it is a much more personal environment. But so I suppose there's two things, and we need national initiative to get the right information, but also to make sure that palliation is as available in the care home as it is in hospices, which I've always sort of thought is a sort of more privileged death, really, for the smaller number of younger people with cancer. And these are older people mostly, but not always, with dementia. And it is harder to get the amount of palliative care, especially as GPs are very worried about the amount of morphine and other
Opioids,
drugs that they'll go into people. And with my parents in different care homes, 400 miles apart and 3 years apart, I was able to say, give them more. The amount that they need is what relieves their suffering. And they listened, because if you're the doctor and the daughter, it helps. But I'm sure there were lots of other people who they were just saying, because like a nurse was saying, we can't give more, saying like they are almost unconscious, but they're screaming, what do you mean? What possible outcome could be worse than this? And we need to have that network going in so that people have good deaths in care homes. And it's not the care staff. The care staff are very good. It's that availability of pump drivers and enough drugs and reduction in secretions, and all of them that goes with it, that will enable this for people not just to die in care homes, but to die as well as they can in care homes.
Yes, I mean, I think there's several ways that can happen. Many care homes are increasing their knowledge and their confidence with palliative care, but every care home should have the 24/7 number of their local hospice to inquire about doses and symptoms that aren't being settled. And we need to do a lot of GP training. There's a huge backlash against using opioids towards the end of life, when that is the right time to use them. People, if you ask 1,000 people how they want to die, not talking about assisted dying, they'd want to die in their sleep. So sometimes you have to help people to be asleep.
Yeah. And syringe drivers for people
Yep.
who cannot swallow and they can't wait if it's Friday
Yes,
till Monday.
well, I am leading a project on needle-free approaches to symptom control because syringe pumps are complicated. We may be able to manage without them for many patients, but there are, I think, introducing some of this creativity and innovation is really important. And I think hospices and I know here that we link in with North London Hospice and with Trinity Hospice, with Nightingale in South London. So I think there's lots of shared learning, and hospices need to learn much more about dementia.
One question from me. I'm Nuno. You talked about financials, and I think it's important to talk about it as well.
Okay, yep.
We know,
Yeah, carry on.
we know that dying in a hospice is much more expensive than dying in a care home in general. Now that some hospices are close to the end of their lives because they have no funding, how can care homes contribute to provide high quality end-of-life care, having to account they are not hospices and they don't have the same resources?
Good question. Yes, many of you will have read about hospices' challenge for funding. Most hospices are 70% at least funded by the local community. They were developed as charities and have stayed outside the NHS for better or for worse. So they are funded 30% by the NHS and 70% by charity, and the care is free. Care homes obviously have multiple different streams of funding. Some residents are funded by their families or themselves. Many are funded by social care or NHS fast track funding. So completely separate funding models. I might be being recorded. I'm not sure very small hospices will survive. And I think all of end-of-life care will become a combination of hospice and care home in the future. And I think many care homes will probably set up charities to try and fund the extra care. If I owned a care home, that's what I would be doing. So I would be trying to provide some free care. I do know a businessman who's buying up care homes around the M25. He wants to provide 10 beds of free care, free hospice care, but funded by long-term care for 60 other people. So I think there are many models, and I think South Africa has developed a very interesting long-term care model funded by insurance, but again, free care for people towards the end of life. So I think we've got to be creative about funding. But I think from the statistics I showed at the beginning, many more people are going to be ending their life in care homes than we imagine now.
Hi, mine's more of a statement, but I'm interested in your comment. Maternity care is free. Hospice care is not free. How, as a society, have we arrived at that?
It's really strange. I don't know, because the rest of the world, I mean, the UK led the development of palliative and hospice care, and Europe and North America have followed suit in developing hospice and palliative care, but it doesn't rely on charity in any other country. So it's very bizarre. I think hospices have shot themselves in the foot. They've tried to stay away from government and felt that that would lead to more independence and creativity. I personally would like to be 90% funded by government and have 10% for creativity. And I think maybe that's the way we'll go.
Thank you.
And I think to say that how people die does live on in the memory of those who survive. And I see many distressed people in bereavement where there has been a pretty awful ending, and it tarnishes the survivors for a very long time. I don't want to finish on that sad note, though. One last question.
Yeah, I'm just, because mostly of our residents, sometimes in their advanced care planning, they prefer hospital admission, and then they suddenly deteriorate, and then the power of attorney will decide to bring them in the hospital, and then we will know that, and their reason is hospital can give them like IV antibiotics, and then they can provide more that we cannot provide in the care home or in. So my question is, moving forward, is it possible for the care homes to give IV antibiotics as well, or any intervention that, you know, the power of attorney or our residents will be, oh yeah, we can stay at care home. And then because as part of the care team, knowing a resident died in the hospital without their family, it's really sometimes it's emotionally
Very difficult,
distressing. So that's why that's my question. Is
Okay,
it possible?
2 quick answers. You can always have another conversation. So when somebody comes into the care home, it may be completely appropriate to go back to hospital for some intensive treatment. But as somebody deteriorates, you need to have another conversation, either with the resident, if they've got capacity, or with the person with lasting power of attorney, that the hospital may not be able to, may increase suffering rather than prolong life. It's back to that slide which said, you know, do we really want to squeeze out a bit more of biological life? And the second answer is yes, we can give subcutaneous antibiotics once a day. We are doing that much more in the hospice. Well, I mean, we do cannulate people and give lots of intravenous stuff. There's lots of subcutaneous options, and I'm being told to stop now, so I better stop. Yeah.